Well, good morning again. It's my last time at the podium, and so I first and foremost want to thank the Saudi Heart Association and the whole team for being a superb host. It's been a wonderful 2 days, and also you've been able to get your people out, and I think it looks terrific. I also want to say that I first came to Saudi Arabia in 1982. That was about 2 years after Dr. DeBakey stopped coming to Riyadh, and I've been here every year since. So in 30 years, I have to say that the improvement that I've observed is fantastic. I think all of you, whether you're physicians, nurses, or technicians, really should be congratulated to see what tremendous improvement has happened in the quality of care in those 3 decades. I saw it mostly from Riyadh, but I'm sure many of the people who trained with me when I was in Houston as head of cardiology, and for the past 10 years in University of Ottawa Heart Institute, all of them who've come back here have all done well, and I think all of you should feel very proud for what you've done. Thank you. My topic is an unusual one for me. In 1998, I identified the first gene for atrial fibrillation, which clearly has nothing to do with this particular topic. I can also say that some of you who know me, I'm an avid tennis player. I play about 3 or 4 times a week, mainly at night, but sometimes I travel with my colleagues to cross Canada and to Florida playing tennis. And 8 of us, 4 of them have atrial fibrillation. I've recommended ablation. All of them had it done twice. They're all free of atrial fib, and we're still winning. That's probably as close as I get to this topic that I shall be talking about. So I really, as John said earlier, tried to give you an objective, brief assessment, really looking at ablation, as well as what my colleagues who do it every day at the Heart Institute. So the topic was given to me. I hope I can. Sorry, I'll go back a little bit. That I don't think I need to remind this group that atrial fibrillation, since you heard already from our friend, that it is truly an epidemic with over 30 million people in the world at the moment with atrial fibrillation. And as you know, that the world is getting older and older. The most recent statistics in the Western world from 1990 to 2010 is that lifespan is increasing 1% per year. So at the end of this century, the average lifespan of a human being in the Western world will be about 160 years. And if you look at the numbers as we see it today, that by the time you reach 100, 110, atrial fibrillation will probably be occurring in about 40% of the population. So clearly there is a lot to be done, and the complications are costly, both in terms of quality of life as well as financially. I think you have a timer on, so if you could. Now, the New England Journal article, I think you have a timer on. Can you take the timer off? The AFFIRM trial, which I was given to follow up on, as you know, was a randomized multi-center study comparing converting atrial fibrillation and using antiarrhythmic drugs versus leaving them in atrial fibrillation and simply controlling the rate. And the rate was at rest somewhere around 80 beats per minute, at exercise up to about 100 beats per minute. So the story, these are the drugs that were used. As you can see, a long list of drugs, all of which have their own side effects, none of which have ever been found to be that effective, perhaps with the exception of amiodarone. On the other hand, it has a lot of side effects. The drugs used to control rate are the usual, not very effective, but it's basically what we have to do so. And what they observed in the AFFIRM trial was, in fact, that whether you converted them and kept them in rhythm control or simply controlled their rate. I'm sorry, you got it on a timer? Obviously, the guys over there don't like me. They always have something wrong with my side. Can leave it there. That as you can see here, that basically what you observed was a wash in the sense that it didn't help to keep or convert the rhythm and keep it in sinus rhythm. So the bottom line to this study was, given everything else, it was just as well simply to control the rate as it was to try and keep them in sinus rhythm. And there were more adverse effects from the drugs, longer hospitalization, and so the story at that time was the firm said, don't spend too much time trying to convert them because one is just as good as the other. Now, my point to you is I think that has changed 10 years later because of something called ablation, which at that time was certainly minimally involved and a new and experimental procedure. I do think today that this is no longer considered to be the state of art, and that ablation as a treatment for atrial fibrillation, I think, has improved significantly, and clearly you'd have to relook at this situation, as I think that most of the guidelines are doing. But before you think about ablation, I just want to remind you that it is primarily, most of the research, most of the practical clinical data is tied up with paroxysmal atrial fibrillation, which, as you know, is when you just get it periodically, and they've defined it as less than occurring 7 days. On the other hand, persistent, which can occur up to a year, or long-lasting, more than 12 months. These are arbitrary classifications that electrophysiologists have decided to go with. So what I'm going to say, most of it, if you looked at the routine treatment over the past few years, if you had paroxysmal atrial fibrillation, one would be, if it was very rare, you probably carried a drug like amiodarone in your pocket and took it and converted it. Whether it really worked that well or whether it was so short-lasting it would have anyway remains to be determined. If it was more common than that, you probably then took one of the antiarrhythmic drugs daily. And if neither of those work, you then went to ablation. In most of the studies I'm going to show you are very small numbers over very short intervals, and so this is more or less all we have to work with. If you look at this study here, 140 patients in each group looking at catheter ablation versus antiarrhythmic therapy, and it was concluded that more people remained free of atrial fibrillation than in the drug group. Here's another one, 66 patients in one versus 61. I'm sorry, it's on a timer, so the thing is moving on its own. But what this study did show again is that more people stayed atrial free, better quality of life, and yet small numbers clearly. If you can hold it there for a second. Okay. So what I want to say to you is that even if you look at all of the literature, that you won't see many long-term follow-up studies, but the ones that have been done with the small sample sizes all indeed show that, in fact, ablation is better than in that group with paroxysmal atrial fibrillation. Now, the other thing to keep in mind is that most centers recognize that a single ablation isn't probably going to do it. At our institution today, when they come for ablation, and if they're candidates for ablation, we tell them that you may have to get 2 or 3 ablations over the next year or 2 in order to get the best results. And I think this is generally recognized across many of the better centers. What I've done here is pulled out the literature. Sorry. If you look at those numbers, these are the best numbers in the literature for ablation. And most of them had 3 ablations or 2 ablations to get those numbers. At our own institution, we tell people we expect with the first ablation to have a 70% success, with the second 80%, and with the third in the 80s. Now, these are 2 reported errors you can see with 5 years. Of course, the numbers are very small, but I think this is probably as good as you're going to see. Most of these people had 2 or 3 ablations. And these are the complications. Again, these are very similar across all of the centers. You can see here tamponade still remains probably at 1%. Institutions are reporting a stroke rate of lower than that, but again in the 1% range. Hospital mortality is certainly low and less than 1%. So that it also is recommended that if you're going to get ablation, it should be by someone who's already, and the electrophysiology guidelines, who's done 25 or 50 of those procedures. It is important to emphasize that all candidates for ablation should get anticoagulation, both prior, during, and after the procedure. How long after the procedure? It does vary. Some people will stay on it. Part of the problem is even when you get ablation is successful, they do have asymptomatic episodes, maybe for a few hours or a day. Is that making them susceptible to get stroke? If so, everyone stays on an anticoagulant in most centers for at least 6 months. After that, if they're atrial fib free and monitored, some people stop it, others continue it. I think that's still an open question, but not for the first few months. And I think a couple of points that the electrophysiology emphasize here is that you probably should never do ablation for the sole reason to avoid anticoagulation, because you're probably going to end up on anticoagulation for some time and maybe for a very long time. The other point is that if you've got a high risk profile for thrombosis, even if you're successfully converted, you still should be on anticoagulant. And I think that it's open as to if you record these asymptomatic short episodes, should you remain on long-term anticoagulation? I think it's an open question at the moment. So in that sense, I think the AFFIRM trial is out of date for paroxysmal atrial fibrillation due to, I think, the results we have. Certainly in some people now, it is considered to be a primary therapy over antiarrhythmic therapy. I think it is questionable what categories, but the new guidelines for the Canadian Cardiovascular Society that came out 2 weeks ago, and I think they will reflect most of what people's thoughts are, that someone who is in paroxysmal atrial fibrillation and are highly symptomatic to go and get ablation as a first-line therapy. If you're having multiple recurrences of your atrial fib, even though they're paroxysmal, that many will consider ablation as first line of therapy in that group. Another is those people whose quality of life, I'll go back to my colleagues who play tennis, they play tennis much better when they're in sinus rhythm than when they're not. And they will tell you that they have lots of symptoms when they go in and out of atrial fib. And whether it's placebo or not, I want to tell you that all 4 of them who have been converted, we played our last tournament in Miami and we won all of them. That was after their ablation. So I think there is something to the quality of life that people have when they're in sinus rhythm. Not surprisingly, given the fact that physiologically a quarter of your cardiac output normally comes from the atrium, and you do benefit from that. The other is if you happen to have an arrhythmia-induced cardiomyopathy, then obviously catheter ablation, a rare but one that would be preferred. I think it's been long accepted that those people who, with antiarrhythmic therapy, remain symptomatic, then obviously ablation has been for some time now, probably 4 or 5 years, considered for these people. And I think, again, emphasizing this is one procedure where you do need to have the proper equipment and the proper expertise to do what you have to do. So only experienced people with the technology, I think, should do this. I mean, today, most people are using the array and using radiofrequency of the pulmonary or cryoprecipitation. Both are working well. Both give similar results. But you have to know the mapping and what you're doing. Now, I haven't said anything about persistent atrial fibrillation. Certainly, lots of ablation has been done, but the results have been far more disappointing than the paradoxical atrial fibrillation. I just want to leave you with a couple of thoughts, because this was recently published in Circulation by the person who really is considered to be the founder of ablation, certainly for the pulmonary arteries. And what they've done here is a very interesting, I think, story. They developed a 252 body surface electrode, so you can do it, just put it on the body non-invasively, and using non-contrast CT, they can connect the electrical activity with the anatomical sites, as you can see here. And they did more than this. I think very important thing that I would see about this paper is shown here. People who came in atrial fibrillation, who had persistent but went in and out of it, were now in it when they were seeing them. They mapped them the night before, and then they went on and mapped these people over the next few months. And what they observed is that when you first come in with persistent atrial fibrillation and you've only been in it for a few days or over a few weeks, they found 2 loci, 2 foci for that one. But if you were in it for 3 months, they found 3, 4 to 6 months average 4, and at 6 months, 6 foci, and then at the end of the year, most people did not go beyond 6. But almost 75% of all of these new foci were not in the pulmonary arteries, they were in the left atrium. So they went ahead and they ablated those particular foci in the atrium as well as in the pulmonary artery. Sorry. Guess I went the wrong way. They went ahead and ablated all of these, as you can see at the bottom there, that 85% of the patients were free of atrial fibrillation taking that approach. Now, how long they will be free, obviously there's no follow-up, but I do think that this is a very interesting, because it means people who go from the paroxysmal to persistent, it looks like it's often because they're developing new foci, not necessarily in the pulmonary artery where you're ablating, but also in the left atrium. And if you don't do both, you probably won't get the results that you're seeing here. Now, 85% is high. We do not know how long it will last, but I do think it is a very interesting paper, and so I leave with you that ablation as a primary treatment for paroxysmal atrial fibrillation is clearly here, and certain indications would say go for it. On the other hand, looking at the data that's just published for persistent atrial fibrillation, it too may be around the corner that ablation will become, and all of it will say to you, as I have always told my colleagues, it's better to do it earlier, because the longer you're in atrial fib, you start to generate more of these problems. And so I think that the ablation technique is looking better than ever, not just for paroxysmal, but also for persistent. Thank you very much.